oh my gosh, this person wasn't here or that person wasn't there.
Where's the barcode located at?
If you can do the barcode here, please, please.
Okay, I'm gonna have to switch because I was on my phone and because my computer is acting up, so I'm gonna have to switch to see if I can do it.
Can somebody screenshot that and send it to me? I'm on my phone. I'm driving.
Yeah, let me see if I can do that.
So who's still having a hard time with this? You got it? Most of you? I don't see Derek on here. Everybody else. So Claritha, you're having a hard...
Yeah, I'm trying. I'm gonna try right now. Hold on 1 second.
Do you need me to hold the thing up again?
Yeah, I'm gonna unlock your phone. I'm gonna take a picture of it with another cell phone, and then I'm gonna try to scan it.
Okay.
Okay.
And this will be the same.
Huh?
I just sent it to you too.
You send it to me?
Yeah, I texted it to you.
Thank you. Hold it over in the go up some a little bit. Right there. No, up.
Right there.
Stay right there. Perfect. All right, 1 second. Okay, now I'm gonna go to course key, see if it works. Okay, pictures. All right. Oh yeah, I'm in. It works.
Awesome. So who, I think there was one more person. Was it Celicia who was having a hard time with it?
Yes.
Did you get it or not?
I sent it to her. Let's see if she can do it. And I sent it to Ione too.
You are so helpful. Thank you. So I think that there's only one person who's not on the call. Yes, he is. I can see Derek, I think. Is that Derek down there? No, that's Melissa. Patrice is here. Melissa Dickerius is here. Evelyn Roberts, maybe. Yep, she's here.
Can I see the code again?
The code? Of course. Yeah. Tell me if you need me to hold it differently. How's that? Did it work?
I can't see it.
You can. It's right there.
I'm having trouble getting in.
Okay. I didn't think to scan it any other way. What's the problem with it? Your phone can't see it?
Yes, ma'am. Because I'm on my computer and my phone, and I can't get, and it won't let me scan.
That's strange.
Do you have two devices? Like are you using your camera off of your cell phone and then using the computer screen?
Yes.
I don't know what else to tell you. There's a code, Atrice, in the chat. Do you want to try putting that code in?
Okay.
Um,
Do you mind holding it up one more time? I just swapped my
course.
phone to my computer.
Can you
Lower.
see it? Is that
Perfect.
right?
I got it. Thank you.
Would you, I don't know if you have Atrice's info, whether, I don't know why it won't. That's so weird how it works for some people and not for others. Strangest thing. So strange. Well, I've checked everybody off. I think there's, let's see, 1, 3, 6, 9. Huh. There's 12 of you, right?
Yes.
Let me just look at this. Iona's here. Celicia's here. Ione, Celicia, nice. Claudia, Beatrice. Is Derek Merriweather here?
I don't see him yet.
Mm-mm. So it's 12 of you. Hang on. So let me just go from the top here. Melissa Emmerich. I'm just looking on this thing. Celicia is here. Beatrice. We have a lot to cover tonight, ladies and gentlemen. And what I'm going to try and do is I wanted to email you all this session, but what I'll do is after this recording, I'll email the recording to you. I'll download this recording and email it as like a YouTube video to your emails. And I'll also email you the notes as well. There's a whole thing of notes here. When are you in class? I'm not sure what are you evening classes? Are you there like twice a week, or when's your next class?
Tuesday, Wednesday from 6 to 10.
Okay, so you're there tomorrow evening, right?
Yes, ma'am.
Perfect. So I could make a bunch of copies of these for you because I'm going to be there tomorrow during the day. So is it who's teaching you tomorrow night?
We have no idea tomorrow. It's Gilchrist is at
Usually
on this week.
Oh gosh. Well, who's been teaching you generally? Is it just been different people?
So normally it's Kilcrease, but she said that we would have different teachers this week specifically. Like she said that possibly Wednesday when we take our midterm, like the ADON will be there, but she's not really sure who it was supposed to be specifically, so we're not quite sure.
Okay. All right. Well, that's interesting, right? But generally it's Miss Kilcrease, right?
Yes.
Okay. Well, I have all your emails from here, so what I'll do tomorrow is get these notes sent to you. That way you can sort of have them as a review packet or however, whatever works for you guys. Ione, where's Ione? I saw your name. Okay. So Derek's not here. Evelyn Roberts. Yep. Andrew. And Stacey Williams. What I'm doing is, so what I've done, guys, is I have like a checkoff sheet. So if there's some issue with the course key, at least we have a checkoff sheet of everything. And of course, with the fact, that this is being recorded, if there's any dispute as to whether you're actually here or not, we've got it in recording, right? So, so don't stress. It can always be rectified, and it's just one of those things. Sometimes it's like that, right?
Can I try again? I think.
Of course. Where do you want it? Right there? Did it work?
Yes, it worked. Thank you.
Hooray.
Sorry, I think it's my phone because I'm at the school because my internet is not working at home, so that's why I'm like trying to.
Oh, you were at the school?
Yeah, because my
I'm
internet
sorry.
isn't
Did
working.
you did know, now all of you I think got a phone call or an email at least to say about tonight, correct?
Yes.
Okay. Okay. All right. So farm. Well, a couple of things I'm going to do. This is the sort of flow. I'm probably not going to do 4 hours because, gosh, you poor guys, you 4 hours of farm. That's enough for anyone, right? Including me. I've just done 3 hours earlier today. But we're going to I want to go over the big topics. Last term, I think it may have been Deb or Miss Kilcrease that said to me there were certain areas that seem to be crop up again and again and again that are issues. So what I did was I went into the farm files and looked at various pieces that I wanted to go over. So I'm going to go over each section with you guys. We'll have breaks. I'm also going to do a quizzes. Maybe, I mean, if you want, we can do that first as a sort of test to see where you feel with your knowledge base. And that might sort of just get the juices going like, oh my gosh, I forgot about this and I forgot about that. So that might be a good place to start. It's, I don't know if you're familiar with quizzes at all, Q-U-I-Z-Z-I-Z or something like that. Have you ever tried it? A bit like Cahoots. You ever tried it?
No.
Not that specifically. We've done Cahoots.
We like
Okay.
Cahoots.
It's sort of similar to Cahoots. It's called quizzes. Well, you know what? I'll give you a break on that because we've already had some technology stuff, but I do want to do that. So probably about halfway through, I'm going to do it. So quizzes is a way that all of you can work together. It's an app. You just download the app and we'll do this quiz. But it's sort of fun. And the other thing, of course, I want to do a little bit of dosage calc as well. And the way that we'll do that is I want to do a mils per hour one, a microgram per kilogram per minute one, and probably, do you have any others that you have issues with or that you're concerned about? Yes.
I'm always bad with the Pitocin.
Is that a microgram per kilogram per minute type of one?
Well, it's like the units to milliunits.
You'd have to show me that. I'm not sure what you mean by that. Can you see this screen? I don't know if that's a good
with
one.
that one, triggers, it's just like, I just had to break it down like the way we learned.
Yeah, I mean, as long as you get the concept, I mean, whether it's, and that's something that I think we can talk about because whether it says unit or milliunit, in your brain, think microgram and milligram, or, you know, it's a unit. It doesn't matter if it's MEQ, it doesn't matter if it's milligrams, it doesn't matter if it's units, it's still going to be, it could be jelly beans, you know, jelly beans and 1,000 jelly beans. It's the same thing. So I'll do a few different ones and hopefully that will help. Like for instance, we'll do a heparin one. Whether it's heparin or Pitocin, it's still, heparin is in units, correct? So that might help you a little bit if we do a couple of those types of things as well. But I'll be happy to do them. So we'll do some of those, but let me minimize this. I'm going to go to downloads. I'm going to share my screen in a second because I'm going to start talking about, first of all, antacids is where I'm going to go. And I don't know what you remember or what you do remember about antacids, but we'll go there, unless you want to do the quiz first. Show of hands. Who wants to do the quiz first? Anyone?
Sure. Doesn't
You want
matter.
to do the quiz first? All right. I think that would be a good starting point. Let me go there. Just going to minimize you all. In fact, we could do it all together. It's 25 questions. It was just fun. But if you haven't downloaded Quizzes, which is sort of a fun thing to do, let me see if I can share my screen with you guys. And give me a second. Can you see this Quizzes thing right here? Can you all see this? Yeah, okay. So Quizzes is, as you can see, it's sort of quite cute. It's a way of doing it, and I suggest, I mean, it's just another tool along with NCLEX Prep or whatever you want to do. You can have your own library. So this is 25 questions. Normally you all play together. And what I do is normally I give you a code, just like Kahoots, and you guys play against each other. But why don't we do it this way instead? And you can all shout out the answers, or however you want to do it is fine with me. So let me just move you all over here. So I'll present this here. So first question for 100 jelly beans. Who can answer this one? Anybody? This med is used as a short-term anticoagulant. What would it be?
Heparin.
Heparin.
Heparin. Hallelujah. Better be. Show answer. Yes, it is. Good.
Derek.
There's Derek. Did he get in?
Yeah, I let him in.
Yeah, there he is. Awesome. All right, everybody's here. Great. Great, great, great. All right. So let me go back. There's a way, I think right there. Oh, I don't want you to see all that. All right. Next one. Rapid infusion of this med can cause red man syndrome. What would it be?
Vanco.
Yeah.
Vancomycin. Good job. Just in case you don't believe me. There you go. All right. There's got to be a quicker way to do this. All right. This medication is frequently given to people with AFib or a history of stroke to prevent another clot. What is it?
Eloquent.
Yeah.
Eliquis it is. Good job. You're doing great. All right. I don't know who's answering. See, this is the thing. If you were doing it as a quizzes, then I could see a sort of like a, what's the word I want? Like a bar that lets me know who's answering. Hopefully all of you are. All right, next one. Another name for this medication is ondansetron. I can't even pronounce it, but what is it?
Zofran.
Thank you. All right, now you know that a lot of these, this would be probably on the HESI, not this, but even if I can't pronounce it, you still know what we're talking about, correct? All right, all of the following are narcotic pain meds except
Toradol.
Toradol.
Toradol. Toradol is an NSAID. All right, good job. This med is frequently given conjunctively with, I think this is bowel, antibiotics or prophylactically for patients with frequent diarrhea. What is it?
Lactobacillus.
Correct.
Yeah, that thing.
Correct. It is. It's a probiotic. All right. So I always say if you're giving an antibiotic, you always want to give a probiotic, right? You're always going to give the opposite, always. Okay. What's this one? This med is regulated by monitoring the TSH and what is that one?
Synthroid.
Synthroid.
Yep, good job. Look, see, you guys are awesome. This med acts as a vasodilator to reduce the blood pressure. What would that be?
Nitropase.
Mm-hmm. Hopefully. Yes, it is. That could get confusing, right? Okay. A common side effect of this med is GI upset. Additionally, it needs to be held for 48 hours after contrast. Yes, you are right. Metformin. You guys are doing awesome. Oops, come on. All right. This med is administered during preterm labor or for preeclampsia.
Magnesium sulfate.
Magnesium sulfate.
You got it. That's not my field at all. That's Miss Fails. This med is an anti-epileptic.
Gabapentin.
Which one?
GABA.
GABA. You got it. GABA. All right. This med is an NSAID given IV. Which one is that?
Naproxen. Naproxen.
Naproxen.
IV. IV.
Oh.
Ketorolac.
Yep. You got it. Or Toradol is the other name, by the way.
Okay.
Yep. This med is given for heart rate control.
Cardiozem. That one, yes.
Yeah.
You got it. Cardizem. All right. A side effect of this med is a metallic taste in the mouth. Now, I wasn't 100% sure of this one, but what do you think?
The first one.
You think it's metronidazole? Probably is, actually, I think.
Yeah.
Metronidazole?
Mm-hmm.
Yeah.
Yeah.
Yeah. All right. Oh, this one. What do you think? No, this one you should get.
Metoprolol.
You got it. Bingo. Anything with a lull, right? It's a beta blocker. Beta blocker is going to slow down the heart rate. Which med is a statin?
Lipitor.
Lipitor. Yes, it is. All these statin. All of the following are benzodiazepines except
Avapro.
mm-hmm. It's a statin. You got it. All right. Which of the following is a rapid acting insulin? Which one?
Glargine.
Humalog.
Humalog.
Yeah.
So Humalog is rapid. This is long acting. This is medium. This is basically regular. All right. Humalog. There you go. If it's got a log at the end, it's rapid. All right. What do we give with Coumadin? What lab values?
CBC, PT, and INR.
Excellent. Good job. You got it. See, this is cool. See, you guys, if you did quiz, if you download this app, there's a lot of different, you can make your own libraries and you can play against each other from home or anywhere. And it's sort of fun. It's got cool music and it's sort of cute and it does cute stuff. Anyway, this medication is given to men with BPH, benign prostate hypertrophy, or neurogenic bladder. Which one?
Tamsulosin.
You've got it. Absolutely. That's the one.
Good job,
Yep.
Red.
I'm sorry?
I call Melissa Red.
Thanks.
Stuff right.
And this is an alpha blocker, by the way. And we're going to be talking a lot about this sort of stuff in a bit. This is given for GERD. Which one?
Protonic.
Yep, you got it. PPI. This is given with azithromycin.
Ceftriaxone.
Yeah, Rosefin, exactly. Yep. Look how good you guys are doing, right? Before administrating whatever, that word. Which of the following? Should the nurse, which one are we talking about?
Vepro?
Yeah, it really can only be that one, correct?
Yeah.
Yes.
I mean, it doesn't make sense, any of the others. It's certainly an iron tablet, a stool softener, flagyl, metronidazole, great for, you know, bacterial vaginosis and GI issues. Avapro really is the only one it can be, yeah? So even if you don't 100% know, you know, you can, this is how you might end up doing some NCLEX questions, right? Which of the following is used to treat high ammonia level? Which one?
Lactulose.
Lactulose, you got it. Yep. All right. While treating a patient with this med, the blood glucose may be higher than normal. Which one?
Methylprednisolone.
You got it. Good job. Yep. All right. As you know, steroids are always going to push up that blood sugar. Okay. So as I say, this is just a fun, I have like a library of stuff. Maybe we'll do this one later. I may even test you a little bit later on a couple of others, but it's sort of quite a cool way of just connecting and somewhat making pharmacology a little bit more enjoyable than, you know, than it usually is, right? Because I know pharm is everybody's favorite, isn't it? All right, I'm sorry, you don't need all that. I'm trying to unpresent because you don't need it right this second. Okay. All right. So as I say, it'd be lovely to see some of your faces. What I'm going to do now is you didn't hear me, Derek, but what I'm going to do tomorrow, I will make sure you all have a copy of this. I'll print out a bunch of copies and I'll email you copies. And on top of that, this video, I don't know if it'll be able to run for hours on end, but I'll try and make sure that you end up having a copy of this if it's useful for you, okay? And what I do want to do is go to my downloads, and I am going to start with chapter 50. I don't know if any of you have your farm books. Maybe, maybe not. No? You were like, no, got rid of that a long time ago. As soon as I was done with farm. Pardon?
It's in another room.
It's in another room?
Yeah.
Fair enough. Okay. Let me just minimize this. Share content. Okay. All right. Can you see this screen?
Yes, ma'am.
Okay. So I am just going to go through. There we go. I'm not in presenting form, but that's okay. There we go. So I just want to start a little bit about GI and talk about some of the pieces that is this still presenting, by the way? I don't feel like it is.
No, it's not.
It stopped presenting. Okay. Okay. I know you can see the other ones too, but you know, at least that way. Who are you guys? I'm going to move you all over here. There you go. That's better. Right. Is it presenting? Yes, it should be, correct? Yeah?
Yes,
No?
ma'am.
Good. So let's just look at antacids. And we mentioned one of them just now, a PPI, didn't we? I want you to understand what's going on in the gut. The gut basically is supposed to produce hydrochloric acid. And when we're healthy, that's a good thing. We want the hydrochloric acid. As we get older, unfortunately, what happens is we have less hydrochloric acid. We produce actually things like histamine, gastrin, acetylcholine. And what happens is when we look at all of these antacids and these acid-related diseases such as peptic ulcer disease, H. pylori, stress-related stuff, ulcers, etc., we reduce this hydrochloric acid, which is what we want. We want that in our gut. So what happens when we've got GERD? Can anybody tell me? I'm going to close this door. What happens with GERD? What types of signs and symptoms do you get?
Yeah, like acidic.
Yeah, reflux, right? You get all of that reflux.
Yeah.
Yeah. So, and this is what happens. We have the hydrochloric acid comes back up because of GERD, because of a reflux type of situation, or because of different, maybe certain foods, certain stressors, all sorts of different things happen. And we have these things, these receptors that are called H2 receptors, which are histamine receptors. We have histamine 1, H1 receptors, and we have H2 receptors. H1 receptors are more to do with histamine receptors related to the bronchioles and related to sinuses and all of that type of issue. But H2 receptors are more related to the gut, all right? So the things that we have are the over-the-counter ones that end in tidine, such as what? Which is not ranitidine, things like that, yeah?
Cimetidine.
Cimetidine, exactly, all of those. We have all of these types of acid-controlling drugs. We have antacids, H2 antagonists, which is the cimetidine, ranitidine, and I know they took, I think, Zantac off the market. I'm not sure if it's still over the counter or not. And then, of course, we have our PPIs, which are in favor as well. So let's just have a quick look at some of these antacids. The antacids that we can get over the counter are different types. Some of them are a form of, I'm going to say aluminium because I'm British and that's how I say it. But, we have different ones, don't we? Magnesium, calcium, sodium, all of these different types of ones that basically cause the acid to be reduced. Yeah. And what I'd like to do, I want to do it as a slideshow so that you can see. Instead, I want to put it over here, and it's been so long, I don't tend to, there we go. That's not what I want. That's not what I want. Sorry, guys. That'll do. Yeah, I suppose that'll do. Yeah. So we have these different types of antacids. I still don't really want that. Sorry, just trying to get out of this end slideshow. That'll do. We'll go this way instead. So you have the antacids over the counters, yeah, many different types, as I say. And remember, the problem is with some of them, like the calcium ones, can lead to things like gallstones or kidney stones or something of that nature, which can be a problem, okay? Things like magnesium ones, if they've got kidney failure, that can be a problem. And ones with bicarb, of course, create an antacid, which can lead to alkalosis, right? Alkaline. So that can be a problem as well. And they really just coat and cause a sort of a nice barrier, but they don't really change the outcome. So let's look at what tends to happen is what we're going to use. I'm going to move forward a little bit with these over-the-counter ones. We're going to use with the tadines, like I just said, the calciums and things of that nature. But the H2 blockers block histamine a little bit. And then we've got our PPIs. Omeprazole, right, is one of them. These block hydrochloric acid completely. And often we give them prophylactically as well. If somebody is in the hospital and they've had a trauma or an illness or surgery, we may actually give some of these PPIs, correct? And then on top of that, we often give PPIs along with a sort of 8-week protocol, including metronidazole, if we're giving supportive therapy for somebody who's got H. pylori. So I didn't know whether you wanted to know more about this, the PPIs, but these are the ones that I'm thinking about and talking about. What's some of the issues with PPIs? How long can you give a PPI for?
Only 30 days.
You can give it a little bit more than
Or is
that.
it 90?
Yeah, 6 to 8 weeks. It is short term, so you're correct in that it's not long-term therapy. And this is the reason why. This is the issue. It blocks all gastric acid. So that's a problem. Because like I just said, you need the hydrochloric acid in your gut. That's important to have it. So when you're blocking all gastric acid, that can then become a problem. The patient becomes achlorhydria, and alkalosis can set in. So as I say, you're going to give these PPIs short term, and you can use it for various different things. You can use it for ulcers, but you can also use it for H. pylori as well, which you're going to determine in which way. Anybody remember how you determine H. pylori?
Stool cultures? Or there's a breath test too.
Breath test.
There you go. Yeah, the H. pylori breath test is really the sort of way to go. It's actually what it is. It's the byproduct of the bulb of the H. pylori that is produced. It's like the urea from the H. pylori that is what is seen when they do this breath test. So couple of other things that I just want to bring out to you is that's been on HESES, it's been on a lot of things, is sucralfate. Anybody remember sucralfate? Sucralfate right here.
It's like you you take it like it coats the stomach before you eat.
Exactly. That's exactly what it does. They call it like the GI liquid bandage because what it does is you can make what's called a slurry out of it. And here we go. I don't know if you can see this here. This sucralfate right here. It is used as a cytoprotective drug. It can be used for stress ulcers, and it creates a protective barrier. And it creates what's called a slurry. It's a huge pill. You mix it in water and it creates like this slurry type of thing. And you get the patient to drink it, and basically it does help form a protective barrier. Another couple of things I want to mention to you as well. Yeah, be aware, don't administer with other meds because it will bind to it, as will a lot of these other medications. Misoprostol, this one I've seen on HESES a lot, by the way. I don't know whether it will come up on the NCLEX or not. It is a prostaglandin. Prostaglandins can have a protective type of effect, but bear in mind, where have you seen this drug? Any other area that you may have seen this terminology or this drug? Just FYI.
Could be used for OB. It's like abortion drug. They use in abortions.
Exactly. So you do want to be careful, of course, with your you know, this is not something you would give to a pregnant woman, okay? Now, I know the dosing is different, but even so, it does have this abortive component to it. So you do want to be cautious with this type of medication, okay? But it is used for gastric ulcers. It is used as a type of GI med. So I do want you to be aware of this particular medication. And as I say, it has come up on the HESI. I don't know if you remember seeing it at all. So this is why I'm bringing out these type of medications. And I want to see if it was on some of the stuff that is mentioned. I know Miss Kilcrease mentioned that, and this is why I've brought out these ones. What else? Let's see. Simethicone, it's an anti-flatulent drug. Milk of magnesia, by the way, antacids. Let me see if that one is in here. Milk of magnesia. Milk of magnesia, it's mixed with magnesium. It has aluminium and magnesium, and it can actually counteract diarrhea, okay? So it's a great type of medication that we can use, but as I say, it can be used as an anti-diarrheal as well. And I think those are the few that I want to just bring out in there. So our PPIs, care with liver disease, make sure you're cautious. As I say, it's only a short-term type of thing that you're going to use. And let's see, here's a question for you. And there's the answer. Chronic renal failure, going to treat with an antacid. Which medication would be the best choice? Not a magnesium one, not a calcium one. You can give an aluminium one, okay? All right, let me unshare this for a second. Okay. So, next. Where are you guys? Okay, can you see this? Belle, you can see these ones? Okay. So let's go with can you see this, or yes, I think it's presenting for you, isn't it?
Yes, ma'am.
Yeah, okay. All right, so antidiarrheals. I know we're starting on a great topic, aren't we? GIs, antidiarrheals, but the main ones that I really wanted to bring out to you are the PPI inhibitors and the effectiveness of them. They're very effective, they're great meds, but they will actually cause complete acid block. So that's the problem with them. But as you can see, they're used for many different purposes. So they're used for peptic ulcers, any type of ulcers, but also H. pylori, okay? So antidiarrheals, I want to just start with these types of drugs, the adsorbents, the antimotilities, and the probiotics. So the adsorbents, Pepto-Bismol, okay, bismuth subsilicate. So with it having this in it, what is this? Does anybody know?
It's aspirin.
Correct. So what types of patients are you not going to give that to?
Under 12.
Who?
The under 12s.
Correct, children. Yes, the risk of Ray's syndrome with aspirin. So you're not going to give it to children, absolutely. Children and teenagers. Good job. The other thing as well is what is it with the tongue? Anybody remember what color the tongue turns with this? Turns black. So Pepto-Bismol can actually turn your stool and your tongue black, by the way. So it's not harmful, but you want to let your patients know about that. All right. Pepto-Bismol. So Ray's syndrome, and it will turn the tongue black. So that's a couple of things to bear in mind with it. Then, of course, we've got anticholinergics. Anytime you see anticholinergics, we're thinking of the fact that it's going to slow down motility, dry everything up, okay? So great type of drugs that can be used. Then we can go to our things like our anti-motility drugs such as opiates, which would be things like loperamide, all right? And then the other one I just really want to mention to you are the lactobacillus, your probiotics as well. You definitely want to have probiotics, okay? So I'm trying to find them. Antidiarrheals. I think that's pretty much all I want to. I'm looking at your list of what they've given me of what you need to go over, but I'm adding to it. I've added a lot more to it, actually. So antidiarrheals. I think that's pretty much it for that. Laxatives, by the way. The real thing I want to bring out in laxatives is that they are very misused, over-the-counter meds. And what can happen is a lot of the time there can be a dependence upon laxatives that can create a problem for the bowel. And actually lead to, previously there may have been non-existent intestinal problems, but now with this dependence they can have intestinal issues with laxatives. Let me see where I want to go next. Antiemetics was not on your list, but let me see if there's anything I want to talk about with antiemetics. Anybody having a burning desire to talk about antiemetics? Speak now. No. All right. You don't want to talk about antiemetics. Fine. Let me put you back here. I do want to go to anticholinergics. Anticholinergics. Chapter 21. Do you remember your adrenergics, your adrenergic blockers, your cholinergics, and your cholinergic blockers? Remember all that? It's been a while, right? Maybe. I lose you all. Share content. Okay. Okay. So let me look at this. So your cholinergic blocking drugs, basically they have a similar, it's the parasympathetic, but it has a similar effect to adrenergics. All right, so it's going to have a similar effect to your adrenergics. So let's just look at what these are going to do. These are your parasympathetics. So, and they're going to predominantly work on the nicotine receptors and also the muscarinic receptors. We want it to work predominantly on the muscarinic receptors, by the way. I wanted to sort of talk a little bit about what cholinergic blockers do. So cholinergic blockers can have some effects, of course, on what? Bronchoconstriction. They cause mydriasis. Any idea what mydriasis is? What is mydriasis?
To do with the pupil. The pupils they dilate.
Yes, and I always say mydriasis, it's got a D in it, and that's how you're going to remember dilation, because it's got a D in it, all right? Whereas meiosis doesn't. So mydriasis is dilation. So anticholinergics, they are going to work on the heart, the respiratory, the GI tract, the urinary, the bladder, the eyes. Those are the sort of areas. And cholinergic blockers can cause things like dilation of the eyes, bronchoconstriction, tachycardic, because they're having the opposite effect to the cholinergic, which is parasympathetic. And also obstruction of urine flow. So they can cause retention. So those are all the sort of adverse effects. But these are these cholinergic blockers. These are some of the ones that you may remember a long time ago. So what are we going to use these types of drugs for? Well, we can use them for overactive bladders. We can use them for bradycardia, actually, at low doses, by the way. It can slow the heart rate down, but it can also have the opposite effect in speeding the heart rate up at high doses. Atropine, these sorts of drugs, so they're going to slow motility down. This type of drug, what's this type of drug going to do? Anybody remember?
So bladder spasms.
Correct, exactly. And then we have scopolamine. It's going to dry out what?
The GI.
Secretions, yes. And we use it as well for, what's the word? If you're seasick, you can use it for those types of reasons as well. And then, of course, we have detroz. Oh, this is another one that's used for bladder, right? Overactive bladder. Okay, so these are all forms of cholinergic blocking drugs. And again, like I said, these are the types of effects that it's going to have on the body. So be aware that it can cause these types of issues, muscle rigidity and tremors. Anticholinergics, it's going to can be used a little bit as well for things like Parkinson's disease as well. Bentyl can be used in that way. So let's see what else. These are the types of issues, or these are the effects that it's going to have. Okay. It's going to decrease bronchial secretions, but of course, unfortunately, too much of it can cause a little bit of bronchospasm as well, depending. It can be very useful for Parkinson's. It can be useful for extrapyramidal type of reactions. Anybody know what I mean when I say extrapyramidal? You remember that from psych?
Is it like neurologic? Is it NMS?
Yeah, extrapyramidal is how do I explain it? The sort of, if you've seen a psychiatric patient or even say a Parkinson patient where they've got too much acetylcholine on board, remember Parkinson's don't have enough dopamine. So what's going on there, they've got too much acetylcholine on board. That's what's going on. So anticholinergics, what they do is actually block acetylcholine. So they're great for that. They block acetylcholine. But if there's too much on board, do you remember the video of the Parkinson patient that he's got that sort of rapid walking and he can't get it together and he can't speak properly? That's a form of extrapyramidal reactions. But on top of that, you've got your psychiatric patient that, again, if you've got a psychotic patient, the problem is with psychosis, Does anybody remember from Miss Thodey's lecture what's going on with the psychotic patient? What's happening with them? Anybody remember? No? Okay. So what's happening with the psychotic patient is they've actually got too much dopamine. Dopamine is the pleasure-seeking area of the brain. So what tends to happen is dopamine overrides everything, and they're like, yay, I just can go out and do whatever I want to do. So a lot of the meds they get put on blocks the effect of dopamine. So they get this extra pyramidal type of reactions where they get weird tics or movements or foot tapping or all sorts of spasmodic type of effects. And that's your extra pyramidal reactions. So, and this is why it's associated with antipsychotic drugs, because we're blocking dopamine. And the reason I'm mentioning this is because this is the type of term that you may see on an NCLEX type of exam, okay? So does that help you a little bit with that? Okay. Again, contraindications of the use of anticholinergics, and let me see if I can, I want to scroll down. It causes bronchodilation, but I want to say cholinergic blockers are, okay. So ignore me with the bronchospasms because I may have misspoken there. I actually want to, here we go. This is where I wanted to go to. So the contraindications, angle closure glaucoma. What type of glaucoma is that? Is that chronic or acute? Anybody? It's acute. That's where it's going to be very sudden, that type of glaucoma, okay? Myasthenia gravis. Myasthenia gravis, we don't want to upregulate more acetylcholine. They've already got too much of it. So, you know, these types of drugs would not be good for them. Things like BPH, we don't want to cause more retention, okay? So, and again, any instability in that way, asthma, these are the types of things that you are not going to use your anticholinergics for. Okay, so let me see. Let me go out of here. I'm gonna stop sharing that. Okay. I want to talk what inhaler would be an anticholinergic that can work as a bronchodilator? More for your COPD type of patient. Anybody remember? No? Atrovent. Atrovent is an anticholinergic. So Atrovent is one of those medications, by the way, you know, that what that's going to do is reduce the secretions. So we can use Atrovent along with, you know, other bronchodilators, SABAs, such as, what's a SABA, by the way?
Short acting. Short
acting beta agonist, right? Which is what? What medication would that be?
Albuterol.
Exactly, albuterol, exactly. So talking about anticholinergics, we said anticholinergics do what? Reduce secretions. So the types of patients that would do well with an anticholinergic inhaler are your COPDers, because they tend to have more secretions on board. So we're going to use something like what? Atrovent. Yeah? You remember Atrovent? I know you do.
Yes, ma'am.
This is why we're reviewing some of this stuff. Okay. Give me a second here. I'm looking at my little list. I told you I have a lot. I am going to send you all of this, by the way, so that you have a lot of this to just go on to refresh your brains about what anticholinergics do as opposed to cholinergics. Anybody remember what cholinergics do? If anticholinergics dry everything up, what do cholinergics do?
Retain fluid.
Yeah, I always go cholinergics because they make everything phlegmy. They actually increase secretions, okay? Whereas anticholinergics are the ones that dry everything up. So cholinergics have that rest and digest type of effect on the parasympathetic nervous system. So just to help you a little bit with that. Let's see where else I want to go next. You know what, seeing as though we are talking about respiratory, let me go to respiratory next. Give me a second. Respiratory. Yeah. Can you guys see that? Respiratory? Okay. Okay. So tell me with asthma, first of all, is asthma reversible?
No.
Okay.
You can control it, but you cannot reverse it.
Well, just in case it comes up on a HESI or I'm sorry, on the nclex or something, it actually is known as reversible. From the perspective, you can potentially reverse it. The difference is COPD is not reversible. Once a patient starts to develop COPD, COPD is known as an umbrella term with emphysema and chronic bronchitis. And once emphysema or chronic bronchitis tends to occur, it's not reversible. Asthma is. Yes, it affects the bronchioles, but it is reversible. So what types of meds do we use for, see, it says it here, it is included in COPD. So COPD is a combination of chronic bronchitis and emphysema, whereas asthma is reversible. So just want to bring that out because, as I say, it's the type of thing that you may end up seeing. So here's your bronchodilators.
Asthma can be reversible, not all asthmas.
I hear where you're going with that. All I'm going to say is, for the sake of prep, let me just pop you guys over here so you can see it. Just for the sake of the potential on the nclex, it's known as a reversible form of an airway disorder. I get that you're saying it is it needs controlling, and there's a lot of different things that we use to control it, don't we? So here's some of them, for instance. Albuterol is one. So what is your rescue inhaler? Because this is the type of thing that comes up on an exam, right?
It's usually albuterol.
It is albuterol. It is only albuterol. It's the only one that is really a rescue inhaler, okay? It might be in combination with other things, but albuterol is your rescue inhaler. That is your SABA right there, okay? So if if it's got albuterol in it, it's your rescue inhaler. Anything other than that is not a rescue inhaler. So bear that in mind if you have a test question asking about rescue inhalers. Now, the other thing I want you to be aware of again, your other inhalers include things like what? These salmeterol, that's a long-acting one, or your steroids, right? Your inhaled corticosteroids would be another one. Which way round do you give the inhalers? Does anybody remember?
When you're doing both?
What if you have albuterol and you have a steroid?
You first open up the airway with the albuterol and then
with
steroid.
what?
The albuterol first.
Correct. And then your inhaled corticosteroid, right? So because you want to open up the airway first, and then your steroid can go in to help reduce inflammation. That's what steroids do. Remember with bronchodilators or with asthma, a lot of the time we have a step up and a step down type of approach, correct? So bear that in mind as well. The anticholinergics, like I just said, that's going to be Atrovent or ipratropium. That tends to get used more in your COPD type of patient. Remember as well with your inhalers, there's different forms of inhalers. The inhaler form, but there's also the elliptor form, isn't there? Anybody know what I'm talking about or remember what I'm talking about with those? That's the one that is the capsule.
Is that like the powder thing?
Yes, yeah. And the teaching would be, of course, that, remember, it's still an inhaler, right? It's the little capsule that goes in there and it pierces and they inhale it, correct? They don't eat it. They don't eat it. So be aware of that for sure.
Wouldn't those be considered maintenance?
Yes. And that's the difference. So your albuterol is your rescue, and all of these other ones, step up, step down, whether it's montelukast, which is singular, whether it's those types of meds along with an inhaled corticosteroid or a LABA or any of those forms, those are your maintenance ones. Those are your long-term type of meds. So just wanted to bring those types of points out for teaching, for sure. And what else would you use in an emergency as well? If somebody is in status asthmaticus, what else should they have potentially?
Nebulizer?
EpiPen.
Oh, EpiPen.
Yeah. So, they may need it for anaphylaxis, right? Just FYI, a couple of things to think about. The other medication, we don't use it so much, aminophylline. Anybody remember the term narrow therapeutic index? Can anybody name some meds that may need monitoring because of that? Because they could be, what does narrow therapeutic index mean? Told you we were going to go over a lot of stuff.
Does it mean it's not, the therapeutic range isn't very long?
Well, it means that there is a narrow range between being therapeutic or toxic. So let's think of a couple of meds that might be an issue with. What about digoxin, right? That's one.
Lithium.
Aminophylline is another one. Vancomycin is one. Phenytoin is one. So when we have these medications where we're drawing blood levels, that's why, because it's got this narrow therapeutic effect where it can become toxic very quickly from that level or not. Or if it's not in that range, it's not going to be beneficial, correct? So that's why we do these levels on these types of patients. So I just wanted to sort of go over that a little bit and just mention those to you. We'll do one more and then I will take a break. You can take a 10-minute break and then we'll, excuse me. And then when we come back, if you want, we'll do a couple of dosage calcs to break it up. Does that sound good? Hopefully I can, and you can join in. Hopefully you can write on the whiteboard and have a go with that. All right. So what did I do? I wanted to do antihistamines. So give me a minute. I'm gonna. Are you okay with this so far? Is this helping you or not?
Yes, ma'am.
It is. It's a lot of information, but I really wanted to make sure that you have as much information to round this out, because I'm not sure what you've been doing and what you haven't been doing, but a lot of this stuff might be helpful for prep, you know, for your NCLEX. Chapter 33. I just want to go over antihistamines with you, because there's a couple of things with antihistamines that is relevant. So give me a minute, I'm trying to find it. Did I know I had you as a group with Miss White, but I can't, which group, what class were we? Was it 1640 adult health?
Far.
I had you for med-surg 1.
Med-surg 1? Okay.
Yeah.
I
Okay.
had you
But
for
I switched from day to night.
Ah, yeah, it was farm. So you still remember some of this? You still remember some of this farm stuff? Apparently you do. Some of you do. I'm trying to find chapter 33. Where is it? Where is it? 36, I'm sorry. Where is it? Give me a second. Here it is. So where have you been doing your clinicals? Have you done a lot of clinicals with COVID and all the rest of it?
We have not gone anywhere.
Pardon? Say that again.
We have not gone anywhere.
Wow.
We have done, me, Melissa Driggers, and Celicia were all together in nights when we had you for pharmacology, and we have not been on site for clinical.
Have any of you done on-site clinical at all?
I have not either. Coming from days.
So have you had the opportunity, are any of you working as MAs, or what tell me what you're up to help you.
I've done my I did a few of my clinicals before COVID happened, and then now that I challenged the LPN board, I'm an LPN now, and I work as an LPN. I think there's another student that works as an LPN, and there's another one that works as a MA, I believe.
Okay. Well, that's going to be interesting for you guys, right? That's a whole new world out there. But some of you are managing to get some experiences. So that's going to be interesting. So are they trying to get you at least something right now to get you out there?
No, not enough time left. There's only 5 weeks, so.
Okay. So the reason I want to just mention, I don't know if you remember with antihistamines. So we mentioned histamine 1 and histamine 2, right? So we've got histamine. Histamine basically is a byproduct of what are called mast cells. So what happens in our body is we have something that irritates us, whether it's pollen or cats or whatever it is that's going to affect us. Some people more than others. And our mast cells, downregulated from the T cells, basically turn around and say, oh my gosh, histamine, prostaglandins, get to work. This poor body of ours is having a really hard time with this, whatever it is that's affecting them, as I say, pollen or cat dander or whatever. And so we have histamine 1 and we have histamine 2. Now, I already mentioned to you that histamine 2 works where? Where did we talk about histamine 2?
The GI.
Correct, the GI tract. And so we have these H2 blockers, right? Like ranitidine, those types of medications that actually block histamine at that level. Here we have our H1 blockers. So our H1 blockers, they block that receptor. So they have a similar effect to anticholinergics. What did we say anticholinergics do? Anybody?
Right.
Yeah, and that's what we use them for, don't we? All these decongestants, these antihistamine type of effects. So H1 blockers, what are they? Any idea? One of them is diphenhydramine. What is that?
Benadryl.
Benadryl. So if you see that on the NCLEX as the generic, which you probably would, then you will know what it is. What type of, I mean, it has a great effect. It is a good antihistamine, but what's the negatives of that type of medication? Why? What are you going to tell your patient with it?
It's gonna make you drowsy.
Correct.
So you don't
It
drive.
is. Yeah, it can make you very drowsy, correct? So that's one of the problems with it for sure. And we have other antihistamines, H1 blockers, don't we? Such as what? That don't make you drowsy.
Cetirizine.
So yeah, things like Lorota, if they end in a dine, like loratadine or phenofexadine, those types of medication, which is Claritin, Allegra, they are non-sedating. They still work. They still have a similar effect, of course. They still help to block the H1 blocker, but they are non-sedating. So let me see if I can find that for you. I want to just find, here you go. These are H1 antagonists. So remember the terminology, antagonists as opposed to agonists. So if you've got an histamine antagonist or blocker, these are the other ones that can be used. So loratadine, okay, phenofexadine. If you see these types of things at the end, basically anything other than this is an H1 blocker, but it doesn't cause drowsiness. All right, so I just want you to bear that in mind for sure. The other thing as well, let's see. The other thing with these other types that are non-drowsy, although some people say they still cause drowsiness, you don't have to give them as much, do you? You can do once a day dosing with them. What about the ones that you spray up your nose? What about the adrenergic blockers, or the ones that they're called alpha blockers, for instance, that you spray up the nose? Is there an issue with any of those by any chance? I'm going to scroll down and see if I can find them for you. These decongestants, these nasal.
What is called rebound congestion?
Good job. That's exactly what I'm talking about. These adrenergics. Adrenergics are great. Adrenergics are going to constrict here. Adrenergics work on the heart, they work on the lungs, and they also work, they can either cause dilation and in other areas, constriction. These adrenergics in this area, when you spray them up the nose, are going to cause constriction. That's great. They're going to decongest, they're going to do what they're supposed to do. But oral decongestants don't have that rebound congestion effect. Oral decongestants don't. But if on your NCLEX it talks about a nasal decongestant, like ephedrine, any of these, then it can have the rebound effect. Flonase is a nasal steroid. It doesn't have rebound congestion, but the adrenergics do. I don't know whether you'll get a question on this or not, but the bottom line is, if it talks about patient teaching and nasal decongestants, and it doesn't differentiate, then the biggie is rebound. They can't use these for more than 3 days. It will cause rebound congestion. All right, so just bear that in mind. That was one of the things that I wanted to bring out, because it seems to be one of those types of things that come up, right? For sure. So let's do, what is it, 7:23. Let's do a 15-minute break for you guys. And let's get back at about 20 to 8. Does that sound reasonable? I want to talk about things like antihistamines. Oh, not antihistamines, I'm sorry, antihypertensives. Let's see what's on your list. Yeah, some cardiac meds, things like that. We have a lot of different things to cover and not a lot of time, but we'll get through it. All right. Is there anything that you specifically want to cover? Hello, hello.
Diabetic drugs.
Which ones?
Diabetic.
Diabetic, absolutely. Yep, we're going to talk about diabetic. Be happy to. Let's see, what have I got? Yeah, we're going to be talking on your list. I've got metformin as one of the things that we need to talk about. Let's see what else I have here. Metformin. Do you remember about your clear to cloudy with your insulins? Anybody remember that? We'll talk about that as well. But metformin is definitely on your list here that I was asked to talk about. So we'll talk about that for sure. We'll talk about some diabetic ones. All right. Let's say 20 to 8, and we'll get back on then, and we'll just have a quick break. Does that sound reasonable?
Yes, ma'am.
Like, yes. All right. See you in a few. Bye-bye. All right. Let's see. You had a quick break. So,
Yes, ma'am.
so Andrew, you said you wanted to talk a little bit about, you know what, I'm actually going to grab, because I don't have all of that in my notes. So what I'm going to do is wing it. And I have obviously a lot of stuff to talk about diabetes. By the way, what's diabetes insipidus? What is that? Any clue?
Fluid in it.
Pardon?
Where your body is releasing too much water.
Fluid. Yes.
Yeah, it's not anything to do with diabetes per se, is it? It's called diabetes insipidus because it's actually to do with the pituitary gland, posterior pituitary gland, with the antidiuretic hormone. Yeah, and so vasopressin is what's going on there. And what happens is the pituitary gland is not releasing this antidiuretic hormone. So the patient is peeing and peeing and peeing like liters of fluid, right? And so it looks like diabetes because there's a lot of fluid going out. So based on that, let's just for a second, what types of, you've got two types of diabetes, don't you? What types have you got?
Type 1 and type 2.
Type 1 and type 2, what's the difference?
One is no insulin production and one is too little.
Well, one is, did you say no insulin production?
One is genetic. And one is not.
Insulin.
What did you say, Celicia?
Insulin resistant?
So, yeah, so, well, let's just talk about that for a second, because what's actually going on is type 1 is, what's actually happening is the beta cells are not producing insulin at all, okay? And you're right, Derek, there is there's genetic components, there's an autoimmune component. Often it is initiated by a big stressor, something of that nature. And these patients have to be on insulin, don't they? They can't be on oral meds, can they? Could they be on oral medications, type 1s?
No, ma'am.
No, no, only insulin. So your type 2s, can they be on oral medications?
Yes.
Yeah, because that's more of a receptor issue. And you're right, it starts out as something like pre-diabetes. And anybody know what the hemoglobin A1C of a pre-diabetic would be like? Roughly?
Be about 8, 7.
About 6 point, probably about 5 point, somewhere in about 5.9 range. You know, because when we're getting up to 6.5, you're diabetic.
Right.
Okay. So, you know, below 6, 5.7, 5.8, getting into, you're sort of pre-diabetic. And what's happening is the receptors are disappearing for insulin. So insulin resistance is occurring more and more and more. There's more glucose on board and less insulin occurring. So what we're trying to do with all of these meds is do a few things, right? We're trying to reduce glucose. We're trying to increase insulin. We're trying to protect the insulin receptors before we have to finally get to the point of giving what? Insulin. So we're going to talk about metformin first because that's really first line. That's your first line med that you're going to give. And that's the one that reduces insulin. That's what we do. So you did a great job, guys, when we had that question about metformin and some of the side effects of metformin. When it causes diarrhea, doesn't it? That's one of the issues, that people don't want to use it because it causes GI issues. Another issue is renal dysfunction, right? Which is why you have to stop it before you give what? What types of things?
Anything with dye?
Pardon? Contrast? If you're going to do a contrast, yeah, you've got to make sure that patient stops their metformin. That's it afterwards, but normally it's pre and post. Okay, so that's a big issue, that you've got to make sure the patient has good creatinine clearance, good renal clearance, those types of things. And as I say, one of the big issues is GI. That's really the dose limiting issue with metformin. What else? Let me think. That's one of the client teaching things. And of course, with a lot of these meds, one of the issues, let's look at the sulfonylureas, like glyphosate. For instance, glyphosate helps to increase insulin. It's a great drug, but the problem is it can cause what?
Hypoglycemia.
Hypoglycemia, yeah. That's one of the big issues. So the patient has to make sure they're eating, right, when they give it. So when you give something like this, they've got to make sure they've got food on board, for sure. Let's see, what other drugs? What other ones? I'm trying to look at your little list. I'm going to talk about insulins in a second, but I just want to see if there's any others that are ones that I want to mention. Yeah, sulfonylureas, hypoglycemia, again, nausea, vomiting, diarrhea. The ones called DDP4 inhibitors, there's a lot of them. There's several different types that are your DDP4 inhibitors. Things like Januvia, gliptins. If they're called gliptins, they're DPP4 inhibitors. What these drugs actually do, these ones help increase a thing called incretin. And incretin, what that does, it helps to increase insulin. So they DDP4 inhibitors, anything that inhibits stops something. So what it does is it actually inhibits the enzyme that breaks down incretin. I know that's a big long mouthful of words that I've just said, but these are the ones that are becoming more and more what is being used. These things that help to prevent the breakdown of this enzyme. We upregulate incretin. And what incretin does is a lot of different things. It helps to increase insulin. It helps to, actually, it's good for weight loss. So is metformin, by the way. It also helps to it slows down gastric emptying. So it does quite a few different things, and there's a few different ones that we can use. As I say, anything that's got gliptin at the end, that's things like Tradjenta is the other one, but linagliptin, allogliptin. So if you see gliptin at the end, you know it's one of these incretin mimetics or incretin inhibitors. The other incretin ones, as I say, the incretins are becoming more and more popular. They're all injectables. And that's another one that's becoming very popular, the injectable type. Let me see which one I want to mention for those. So Onpenzic is one of them, Ozempic rather. And instead of saying gliptin at the end, it's going to say glucotide. So if you see something like glucotide, liraglutide, for instance, that's Victoza. Dulaglutide is Trulicity, or semaglutide is Ozempic rather. These are all ones that are injectable. Instead of blocking the enzyme that doesn't allow incretin to be upregulated, these ones mimic incretin. So they all have a similar effect. They're all going to help upregulate insulin. They're going to help to decrease what's called satiety. Any idea what satiety is?
It's like
Doesn't make
feeling of fullness.
Yeah, exactly. So you have that feeling of fullness, so you don't want to eat as much. So they're great, as I say, to reduce, if people want to lose some weight along with all of this, these are great. All of these types of meds. Either the incretin mimetics, which are subcutaneous, normally once a day or twice a day dosing, or the incretin inhibitors, the DDP4 inhibitors. Similar type of action. Big risk though with these is, like I said, they slow down gastric emptying. So what could be a risk factor with these types of meds, by the way? If you're slowing gastric emptying down.
constipation.
Exactly, that could be, and it could actually cause, if somebody has very slow gastric emptying, obstruction. Yeah, that could be a concern. The other things, as I say, these incretin mimetics, as they're called, the subcutaneous ones, sometimes they're just given once a week, by the way. I'm going to look at exenatide is one of them, and it's given once a week. The big side effect, it's sort of a biggie, all these great things that it does, but it can cause thyroid cancer. All right, that's remember the term black box warning? Does anybody remember that terminology at all?
Yes, ma'am.
Yeah,
No.
so black box warning means, hey, this medication is fantastic, and it is, and we want to use it, but there's some risks involved where we're sort of like, we have to weigh up our pros and cons as to whether we're going to use this or not. Okay, so this is the type of thing. This is a black box warning because it can actually cause thyroid tumors. What are you going to do? Are you going to use that, or are you going to go back to something like metformin? I don't know. But as I say, some of these meds are great. And the nice thing about them is you can just do it once a week. How awesome is that, right? Just inject once a week. That's pretty awesome. So you weigh up your pros and cons. So the big thing for you guys, I would say, looking at this is looking at things like metformin and the risks, like we just discussed. The other ones are your gliptins, like I just said, things like Januvia, which is an incretin. It's an inhibitor of the enzyme that would normally break down incretin, a DDP4 inhibitor. Januvia is one of them. Then you've got these incretin mimetics that are subcutaneous. I'm doing this. I know I'm banging my knee. Where would you give subcu injections, by the way?
You want to give it in the abdomen and rotate it, or do behind the arms like you're giving MMR varicella?
You have to rotate your sites, absolutely. You're going to give it into the fat, right? You're not going to give it dermal, and you're not going to give it IM. You're not going to give it intramuscular. Subcutaneous means into the fat, so it's a little short needle, correct? And there's many different meds that we're going to give subcutaneous, but of course insulin and these incretin mimetics, as they're known, are subcutaneous. So you're going to rotate your sites, absolutely. You're not going to give it close to the umbilicus. That's very painful. And also there's not really a lot of fat there. So you want to definitely give it into the fatty tissue for sure, where it's going to have a better effect as well. So that was one of the things that you needed that was on your list, subcutaneous teaching for sure. By the way, just digressing slightly, Another medication that we give sub-Q would be heparin, right? Or something like Lovenox, yeah? What are those used for?
Those are blood thinners.
They are blood thinners. Are you going to rub it afterwards?
No.
No, why?
I don't know.
So let's think about this. Pardon?
You should do the absorption of the drug.
Well, yes. And let's think about this. If you're giving an anticoagulant and then you rub it afterwards, you're probably going to cause some bruising, maybe a hematoma. You give the anticoagulant sub-Q, whether it's heparin or whether it's Lovenox, leave it alone. You're not going to rub it, all right? Because, as I say, you could bruise the site, cause ecchymosis or a hematoma. So you give it, hands off, okay? But yes, you're still going to rotate sites as well. All right, so let's just look at a couple of things. What would you class hypoglycemia as? What would be the blood sugar?
Below 60 or 70?
70, yeah, 70. Now, this is a type of NCLEX question that comes up, by the way, to do with blood sugar. So this is an example. So the patient his blood sugar is, let's say 65, let's say 70. His blood sugar is 70. He's awake but sweaty, clammy. Would you give oral glucose or would you give a glucagon injection?
If he's conscious and able to swallow, I'll give oral.
Thank you. Thank you. You're not going to suddenly get the glucagon pen out, are you? And bam, give that glucagon pen, right? You don't need to. He's still conscious. If he's unconscious, absolutely you're going to do that glucagon. But if he's still conscious and able to swallow, then you can give oral forms of glucose for sure. So well done, Celicia. Good job. Let's look at a couple of other things. So let's just look at some insulins. First of all, how is insulin stored if it's being used?
In the cells?
If it's being used, it can be stored at room temperature. If it's not being used, in the fridge, right? But you don't freeze insulin though, just FYI. So you're not going to freeze insulin. Do you roll it? Remember in the vial? Remember that way back from funds, rolling that insulin? You're not going to shake it, are you? You're going to roll it. And which way round, if it asked you about your insulin that is NPH, what is NPH insulin? Is it clear or is it cloudy?
Cloudy.
Cloudy. Is it a intermediate type of insulin, meaning it has a slight peak, but it can last about 18 hours, actually, insulin, NPH?
Yeah.
What about your clear insulin? What type of insulin might that be?
Regular.
Which one?
Regular.
Regular, yeah.
And Humalog.
Yes. So let's clarify this a second. So if it's something like Humalog or Novolog, that is going to be your rapid acting insulin, okay? That's your rapid acting insulin. That's going to be your one that peaks in about 15 minutes. So what are you going to teach a patient? What would be patient teaching with that type of thing?
They need to eat within 30 minutes of taking it.
Yeah, normally a bit more than that. I would say within 15 minutes because it's going to peak quickly. 15 minutes, it's peaking. It's rapid acting, okay? Regular insulin is your 30 minutes. Which one can be used IV?
Regular.
Regular, yeah, that's the only one that you're going to see an IV drip done, right? Regular insulin for sure. And then you've got your NPH, which is your cloudy one. That's your intermediate one. I don't like NPH personally, only because I don't find it's very, it's cheap. So if people don't have insurance, great. But there's so many other options that are a bit more stable than NPH. And then what about Lantus? What type of insulin is that?
Long acting.
Long acting.
Long acting. That's the one that is your glargine. Lantus is glargine, or detamere, levemir. Those are your long acting ones that last 24 hours, right? And you only potentially have to give them once a day or maybe twice a day. And that's your, what else is it called? What's the other term? I'm going like this because
Your peak.
it's basal. Yeah, so that's your basal rate insulin. It's just that steady rate in the background. And then potentially you can use the other ones like the short acting, the rapid acting one in between for meals. So those are your 4 types of insulins for sure. One of them is Tresiba, by the way. That's a very long acting one, is a once a day. If you're going to give, say, NPH, which one is that? How long does that one last?
Which one did you say?
NPH.
18.
It's the intermediate one, right? So if you're going to give a cloudy one and a clear one, which one are you going to pull up first?
Clear.
Clear to cloudy. You got it. The reason being is, think about this. If you need rapid acting insulin, you need it to be rapid, correct? You need it to work quickly. Does that make sense? So if I was to pull up my cloudy first and then go into my clear and pull my clear up, there's a risk that some of that cloudy, a little tiny bit of it could go into the clear, which is rapid. So if I need that rapid one, if there's some NPH in there, it could make it longer acting. Does that make sense? So that's why I want my clear first, pull that up first. I'm not so worried if it goes into the NPH, quite honestly, but I'm more concerned about the other way. So that's the rationale behind that. Let's see what else I want to sort of touch on with some of these things. I'm looking. Seeing if there's anything else. The other oral medications for diabetes are what's called the SGLT2s. Those are the drugs that basically help the patient excrete glucose. Okay, that's like Invokana is an example of that. Good meds. What would be a risk with that, or what would be a side effect with that type of med, by the way? When they're excreting a lot of glucose, what's this adverse effect that may occur?
Hypoglycemia.
Well, it's more the effect of, that's a good point, yes. But it's the effect of glucose. Glucose causes yeast. So there's a higher incidence of things like yeast infections, genital yeast infections, because of the glucose that's being peed out. Also a higher incidence of urinary tract infections with those. Let's see. I think that's the type of thing that I want to concentrate on metformin. So client teaching for metformin is, you know, obviously the concern for GI, it's dose limiting, the effect on the renal, on the kidneys, and you're going to monitor those kidneys, right? How would you monitor kidney levels? What would you do? What labs monitor the kidneys?
Yeah, creatinine.
And BUN.
BUN, exactly, BUN and creatinine. And also microalbuminuria, can never pronounce that as well, but protein in the urine, okay? So those are a few things that you may be monitoring for your patient regarding their renal function for sure. All right, so shall we look a little bit at some was that enough for you, Andrew, regarding, did that help you a little bit with diabetes?
That was actually Derek.
Oh, was it Derek who wanted? I'm sorry.
Yeah.
Did that help you, Derek? I don't know if he's... Hello, Derek. Oh, he'll be back in a minute. Maybe. Okay. But remember, it's your logs that are the rapid acting, whereas the regular insulin is your 30 minutes, and that's the only one really that's going to be IV. It's the only one that can be IV. So let's look at, let us look. I'm going to try and find you a heparin one. There's a dopamine one. I want a heparin one because that's got units in it, and I think that'll be helpful. So give me a second. Here we go. Heparin. Okay. Let's see if I can pull up the whiteboard and share my screen, and then this might be helpful for you. Give me a second. Oh. Says I have to, well, let's see if the whiteboard one works. Stop presenting. I don't want to stop presenting. Okay, can you guys see this? Can you see the whiteboard? Anybody?
Yes.
Okay. Okay, good. So let me use one of these. All right, so let's do a heparin drip one, okay? The reason I'm using a heparin drip is because it's got the units, and although it's not Pitocin, it might be helpful, just as a starting point, of course. And then we can do a milligram per kilogram per minute type of question. I don't know what you're going to get on the HESI, on the nclex. I don't necessarily know that you're going to get these type of complicated ones. Seriously, it's probably going to be something like, you know, the desired over have multiplied by volume. I mean, I won't be surprised if it's something as simple as that, quite honestly, that type of formula. But anyway, so let's see. Okay, so we're going to have a heparin drip, and the patient weighs, there's got to be a way of me typing. Can you guys actually play on this while I'm doing it? Can you join in on this or not? I know on the other one you can, so maybe not. 70, can you?
Yes, ma'am.
You can? Oh, great. All right, so we've got 76 kilograms. So we actually have kilograms rather than pounds. And then the heparin protocol, I'm just going to put it all in here. is 70 units per kilogram. It's going to be in fuse. Oops. 17 units per kilogram per hour. Can you see all that? I'd like to make that bigger. There we go, it's better. Okay. I'm just going to put that for concentration is 25,000 units in 250 mils. And it's going to say calculate mils per hour. How many mils per hour? Is this the type of thing that you're talking about that has the units in? Is that what you were saying regarding the Pitocin? Because I haven't seen the Pitocin one, so I'm not sure what that one is. So here we have this. I would love to move this a little bit out of your way. Who wants to have a go at this? Anybody? You remember how you would start this out?
I can't go on the whiteboard. It keeps kicking me out.
Oh.
I'm just watching.
All right. Is anybody able to?
No.
Someone is. I can see someone. Excellent. Yep, mils per hour. All right. So what would be on the top there?
Hold on, give me a second. I don't work around the peer pressure.
I don't see anything.
No pressure. We've got 2 hours.
I don't see anything.
Well, she has put, I don't know how to, I'd like to make this smaller. Make that smaller.
It's like a second little blue screen. So if you hover over your down icons, it's like a little weird blue screen that shows nothing on it. You have to click on it in order to see it. You shouldn't be seeing the instructor. You should be seeing the board.
Yeah.
It says whiteboard, boarding in progress.
Anybody, well, whoever, there you go. So you would put, so I'll talk it while my wonderful person is doing this. I don't know who's doing it. So you've got your 250 mils and your other pair is what? 25,000 units, correct? Which is going to go underneath. Awesome. And then you're going to multiply it. What would have to be the other pair? So I'm just going to stop you for 1 second there. You're correct. You can do it like that. The only problem is with doing that is, well, you could do it like that. You can do it like that. Do it like that, and then your kilogram at the top there. You're going to put your 76 is going to have to go in there at the top. This right here would have to be 76, right? That's going to have to be 76 up there.
Hold on, I got it up there. Hold on 1 second. Hold on.
It's hard, isn't it?
I'm trying to do it my way. Hold on 1 second. 1
Oh,
second.
you do it your way then.
All right, and then it's supposed to be the 1292 times the 250
1292
times the 250. And that's going to be 3. Oh, Lord Jesus. I don't have a mouse
Well,
because my units is crossed out. Over. I don't have enough space.
okay. Let me see if I can. Here you go. How's that? Is that better?
There we go. And then.
Oh, you've gone below. Okay, I see what you've done.
Yeah, because I didn't have enough space.
Gotcha. It should work out. I always cross out my zeros, by the way.
Yeah, I don't know how to do all that. That's the fancy way.
Like this, zip, because you've got 3 zeros here and you've got 3 here, and then it would just be 25 into 323. You could do it that way, but you do it your way. Tell me what you get.
I'm lost. Let's see. So I already did. They want an hour.
So it's just 25,000 units into 323,000. That's it. That's going to be the answer once you've got that. Yeah. 12 point. Actually, it's there you go. Awesome. Good job.
13. You rounded up, right? Or no?
Yeah, that's correct. 12.92. I mean, obviously, if it said just round to the nearest tenth, then you're just going to do 12.9, right? 12.9 if it said round to the nearest tenth mils per hour. So, yeah. Now, is that, I don't know if that's what you mean when you're talking about issues with units. Is it just that it says units, or is it something else that is a problem? Just trying to clarify. Hello. Anybody? Let us look at a dopamine one. Let's do a dopamine one because it's one of those. So that's just a basic mils per hour one, isn't it? You started out with your mils per hour. You recognized that you've got to have your pairs. You've got to flip it the way that it's going to work so that you can keep what you want, which in this case was this and this. It said hour, you've got hour, and therefore you've got to get rid of everything else. You've got rid of your unit here, and you have your kilogram here. You could have stuck another one here and just put kilogram, boop, 1 to clear that out, but ultimately it would have just been the same, if that makes sense. Sorry. Oops, where are we? It still did the same concept. You still had to multiply across the top and get this, and then of course you've got this on the bottom, and it led you to this. Some of them, of course, are not going to be as complicated with the kilograms and all that stuff in it, but the concept is the same. 13 mils per hour if you what? Round it to a whole number. So that would be your dimensional analysis for that. Let me get rid of all this. Thank you for your hard work. That was great. Let's do another one. Anybody else want to have a go at this? Should be able to delete that whole thing, right? How do I delete it? How do I delete it? Let's try that. There we go. Sort of fun. All right. So let's do this next one. Let's do a microgram per kilogram per minute, because that's one of the ones that I'm looking at your list here. Some of the issues. One of the things that was brought up was aspirating with 2 vials. So I think we sort of talked about that, the risk of mixing the med. You're going to pull up your air of what you want. You're going to inject your air, then pull it out, and that's going to prevent you from risking mixing meds when you're pulling up in 2 vials, correct? Let's look at a, well, we've just done a mils per hour heparin one. I'm not sure if that's what she means. There's a couple of things like that here. Let me look at a milligram per kilogram. Remember with pediatrics, by the way, it's always going to be kilograms, isn't it? How many kilograms to a pound?
1.
How many pounds to a kilogram?
2.2.
2.2. 2.2 pounds to a kilogram. And I always say women like kilograms better because it weighs less. It doesn't, but you know what I'm saying? So 2.2 pounds to a kilogram. All right, let's do dopamine. I'm going to write this one out for you. So dopamine. Dopamine, 12 mils per hour. And you know it always gives you a lot of blurb, like the patient is, I don't know, in renal failure and he needs a dopamine drip and blah, blah, blah. I'm not giving you all the verbiage. I'm just giving you the points here. Okay, and it will say patient weighs 70 kilograms. The concentration of dopamine. I spelled it wrong. Oops. Dopamine is 800 milligrams in 250 mils. And it will say something like calculate how many micrograms per kilogram per minute. Yeah? You've seen these types of things, haven't you? Remember these? You've seen a lot of these? Yeah? No? Who wants to have a go?
Which one is this one?
So,
Oh,
this is one of these where it's going to say, you don't see anything. Derek, you don't see anything. Okay.
I can't either. I'm sorry. I can't either.
Fluffy.
I'm just listening because I can't see anything. I can't open it or anything. The whiteboard.
Oh. All right. Well, let me tell you what I've put. That's so weird. I don't know how some people can see it. Huh. What is it that you're doing, Ione, that you can see it?
I don't know. I have 2 accounts with Concord somehow. Let me see what account I'm logged in as. So I'm logged in as my school account, so that gives me more privileges than my personal account.
Okay, that's maybe what it is. If you're not logged into the school account, you're gonna. Okay. Well,
I'm logged into the account. It's telling me something similar to what it's saying to Driggers. It's saying that I'm not a part of this organization. Only members of this ORG can see it. I will be able to see it soon or something like that.
So here's what I'm going to do. Let me tell you what I've, you know what? Let me do this. I wonder if I can.
And I'm logged in. I'm looking and it says that I'm Concord Career Institute guest.
See, yeah, you can see it. All right, so here's the question. So write this down. It's dopamine, 12 mils per hour. The patient weighs 70 kilograms. The concentration of dopamine is 800 milligrams in 250 mils. And I want you to calculate the micrograms per kilogram per minute. So for those of you that can see it, and then what I'll do in a minute is I'll go to the tile and I'll look to see if I can pull up a question there instead. So what would what are you going to do? How are you going to evaluate this problem?
You're gonna all right, so first of all, you're gonna evaluate 800 milligrams into micrograms.
Okay, but how are you gonna what are you gonna write to start this problem out? Are you gonna write, say, microgram over kilogram per minute and then the equal sign?
It's gonna be, is it microgram over kilogram per minute?
Correct. All right, so let's do that. Let's set this thing up. I'm going to get this out of the way a little bit. Okay. So yes, you would start it out with microgram, whoops, per kilogram, dash or the slash per minute. Okay, and then let's look at this. So do we have anything with micrograms?
So
or not?
You're gonna multiply 800 times 1,000.
Correct.
To give you micrograms.
So let's start with our 800 milligrams, right? Here. Over 250 mils. But we know that we want micrograms. So exactly, we're going to put our 1 milligram and our micrograms here. All right, what are you going to do next?
You're gonna multiply with the weight for the patient.
You could do that. Yep.
It's gonna be 70 kilograms, maybe over 1.
Yeah, you can do that. Oops. And then what's the other pair that you need?
So 12 milliliters.
Mm-hmm.
Over an hour.
Okay, let's do that. Do we want hours?
We want minutes.
Correct. So what else am I going to do?
You're gonna be times 1 hour over 60 minutes.
Correct. Hang on a minute. Oops. I'm just going to move this. And let's move this over here a little bit. All right, so let's look at what we've got and what we can get rid of. Oops. I want to cancel this, don't I? And this.
That's the milligrams.
I've got my micrograms.
Yeah, cancel the milliliters.
Cancel my mils. I have my kilogram and my kilogram. Do I want my hour, or do I want to cancel that too?
You need to cancel the hour.
And then I have my minute and my minute. Perfect. So now you can multiply across the top, can't you? 800 by 1,000 by 12.
So 9,600,000.
Yes,
9,600,000.
Sorry, my circles are not very good. And on the bottom, what do I have?
17,500.
Let me just look at this. I've got 250 by 60 by 70.
250 by 60?
By 70, because you've got your 60 minutes by your 70 there.
You have 1,050,000.
Yeah, that's it. So when I was talking about cancelling out my zeros, rather than make it, I tend to prefer to make things smaller like that. I would do that. And then you only have 105 into 9,600 that you have to go instead of all of this into this. And it doesn't matter, but it's just my preference. It's no big deal. So what do you make it?
91.42.
It should be 9.1.
You said 96,000? 96, is that 9,600?
Oh, did I put too many zeros in here? I did. I'm sorry. Let me get rid of one. I apologize. There we go. Now try it. Oops. I apologize. That's my fault.
It gives me 91.4. So is it 96 million over?
It's 96. It's 9600 and then 000.
It's 5 zeros, right?
5 zeros. And then below it should be 4 zeros. So it should be 9.1.
Yeah, 9.14.
Okay. Yeah. And again, if it's just to the nearest tenth, then, it'll be 9.1 microgram per kilogram. Oops, per minute. Okay. Good job. All right. Do you also remember, guys, the formula desired over have multiplied by volume? Do you remember that one? That's sometimes a handy little formula to remember for the more simplistic stuff that you might come across. So just bear that in mind. You never know. I'm sorry that some of you can't see this. That sucks. I was hoping that you could. At least you should be able to go back and see some of this when I download this video, this like 4-hour video that you'll have, which is a long video, that's for sure. All right, so I just wanted to do a couple of dosage calc type of questions. Remember your 9 rights, Okay, so going back, way back to the basics, making sure medication errors, for instance, what type of things would you do if you caused a med error? What would you have to do?
Assess the patient first for any reaction. You want to make sure you notify the provider, and then you want to do an incident report.
Excellent. Yeah, exactly. Certainly making sure you're documenting. And does that incident report go in the chart?
Well, no, you don't put it in the chart. I'm sorry.
Yeah, that's all right. Yeah, no, you don't put it in the chart. Absolutely. No, you do not. Let's see. What else? We're actually doing a lot. There's a couple of things here that, well, I think we talked about subcutaneous. One of the things that is written here is vesicants. Does anybody remember what a vesicant is, by any chance?
It's something that if you push it too fast, it can destroy the cells, tissues, or something like that.
So
I thought it was where it would, like, if it got under the skin, it would actually just kind of cause necrosis.
Yeah,
that's it. Mm-hmm.
You're right. It can cause what's called extravasation. So, some of the chemo meds, of course, are that way, but not just chemo. A lot of cardiac meds can do that. Even dopamine, actually. So a lot of meds, antibiotics, for instance. So they can cause, if they, unfortunately, if they come out of the vein and end up in the tissue, these medications that are called vesicants can cause what's called an extravasation. And it's not just a cellulitis, but they can actually cause necrosis of that area. So sometimes we have to give other medications, like phentolamine, for instance, where we'll give that med because phentolamine, what it's going to do is vasoconstrict. It will cause constriction in that area and prevent the blood, dilation, and just make sure it stays in that area. So I just wanted to explain to you these meds that are called vesicants. What's some of the things that we have to be aware of and be cautious of, do you think? When you're giving an IV?
Patent.
Yeah. How are you going to do that?
Check it hourly.
Mm-hmm. Yeah. What are you going to check?
Make sure there's no redness, swelling, burning, stinging, that the line, like the pump, if it's on a pump, make sure the pump's not beeping.
Mm-hmm.
Touch it. Make sure there's no swelling.
Blood return?
Yeah, blood return.
Yeah, that would be a good thing to check as well. Absolutely. So you're right. That's absolutely what you're going to be looking at. Morphine PCA pumps. Can you let the patient do their own? That's the whole point, right? That they can use it themselves, correct?
Correct.
That's what a PCA is, patient-controlled analgesic. What about the family member? Can they do it for the patient?
No.
Right. That would be an ethical issue, wouldn't it? Absolutely. What's one of the biggest issues with opioids?
Respiratory depression.
Exactly. What's the antidote for opioids?
Narcan.
Mm-hmm. Exactly. Good job. All right. So analgesics. You already mentioned that Ray's syndrome, aspirin, salicylic acid is an issue, isn't it, for children, so you're not going to give aspirin to children for sure. What about acetaminophen? What toxicity can that cause?
Liver.
Yeah, absolutely. So about 3 liters, 3 grams is about where we're going to go. Maybe 3 grams is max. Anybody remember what the antidote is for acetaminophen? I'll be so impressed if you do.
Acetylsalicylate.
Yeah, acetylcysteine.
Yeah,
And it smells like and tastes like apparently rotten eggs, right? Acetylcysteine. Good job. Remember as well that our morphines, remember Dilaudid is 7 times more potent than morphine, correct? Dilaudid? It's much more potent than morphine. What other types of side effects can there be from morphine, by the way? Respiratory depression is the biggest. Any others?
Death.
Did you say death?
Addiction.
Oh, addiction. I thought you said death.
He did.
That's funny. I suppose, yeah, that would be a big issue, right? What about sedation? Yeah. What does it do to the gut?
Constipation.
Constipation. It can cause things like nausea and vomiting, itching. By the way, it can cause like a histamine reaction with some people. Urinary retention is another issue with morphine, by the way, just to mention that. So, all right, let's see what else I want to talk about with you guys. There's so much to talk about. Narcotics, I think that's pretty much. You know what I want to do? I'm looking at your list. I know. Let me talk a minute about. By the way, remember that Toradol is what it's IV, but is it an opiate or not?
It is. It's like a painkiller.
Ketorolac is an NSAID, right? It's actually not an opioid, which is nice because it's great for pain management, but it's not an opioid. You're only going to use it about 5 days, by the way. I'm trying to see where I want to go with here. I do want to talk about. Well, you know what? Let's go to some. I have so much more on my list than some of these, and some of these are not on my list, but that's okay. You remember your antihypertensives? What's a April? What type of medication is April? Ending in April.
Those are herbs.
What?
It's inhibitors.
Correct. It's an ACE inhibitor. Absolutely. What's one of the biggest side effects of an ACE inhibitor?
Dry cough.
Dry cough, because it's an increase in what's called bradykinin. That's what's going on there, and substance P. But bradykinin and substance P is increasing, and that's what causes a dry cough. What's the potential fatal issue with things like lisinopril? What type of reaction can it cause?
Angioedema.
Yes. Crying baby, you can cause that too. Angioedema. Yes. So, and what type of population and race are not a good fit for ACE inhibitors?
African American.
Yeah, we'll go with calcium channel blockers. Absolutely, much better. If somebody has a dry cough, though, we could go to an ARB, and I think one of you mentioned that. So that would be like the sartans, like losartan, that type of thing would be the next thing. And then now calcium channel blockers tend to end in what? What would be the term, the ending?
Zim.
It's a pene, like amlodipine.
Pepidin.
Yeah. Yeah, that would be your calcium channel blocker, all right? And we can also use them for things like Raynaud's disease and propranolol, for instance, Raynaud's disease and migraine headaches. Let's see, what else? And of course, our LOLs. What is a LOL?
Beta blocker.
Beta blocker, exactly, beta blocker. All right. Talking of earlier, we mentioned a vesicant. Cardiac wise, one of the vesicants is nitroprusside, by the way, is a vesicant, and it can turn into something else if we let sunlight at it. If it's not kept in the dark, if it's not kept wrapped in foil or dark covering. Any idea what it can turn into? Pretty serious. And you can only use cyanide, you can only use nitroprusside for about 3 hours. It turns into cyanide. And I want to say you have like a 3-hour window with that thing. So nitroglycerin is another one, by the way. Nitroglycerin IV and nitroprusside can potentially turn into cyanide. So, and nitroprusside, you have to give it, I think the max you can, no, it's 10, I want to say 10 minutes. 10 minutes, nitroprusside. Nitroglycerin, you can give it a lot longer, but there's a risk of if sunlight reaches it, then it can turn into cyanide. So that's a risk, right? That we don't want to look at for sure. Let me see what else I want to look at. If we were to look at anticoagulants, name some anticoagulants for me.
Warfarin.
Yeah. What type of, and which one? What's the antidote for warfarin?
Is it vitamin?
Vitamin K.
Yes, good job. Good job. And what do we want our PT and INR to be with warfarin?
Is it 35? No, hold on.
It's okay. I'm firing questions.
2 to 3.
35%.
Did you say 2 to 3?
2 to 3, yeah.
Yeah, 2 to 3. By the way, this is a question that I've seen. What is the normal INR? It's a bit of a trick question because the normal INR, meaning if you're not on Coumadin, warfarin, the normal INR is like a 1. So if you're not on Coumadin or warfarin and your INR is a 2, that's the problem. It shouldn't be. It shouldn't be that thin. Okay. What about heparin? What's the antidote for heparin?
Protamine sulfate.
Yes, it is. Absolutely. And then, of course, we've got our low molecular. And what are we monitoring? What type of lab are we monitoring for heparin?
PTT.
Good job. Yep, APTT. And what's the beautiful thing about things like low molecular weight, Lovenox, things like that, low molecular weight heparin? Do we need to monitor blood levels? No, we don't. That's the cool thing about it, okay? Let's see. Clopidogrel, or Plavix, as it's called, is also, it's a platelet inhibitor, right? And again, what's the nice thing about things like Plavix? Do we need to monitor PT and INR?
No.
No.
No, you just got to monitor it for bruising.
For bruising, yeah, and bleeding, of course, and diarrhea apparently as well. Yeah, some diarrhea can be an issue with those types of meds. But yes, bruising, bleeding, blood in the stool, hematuria, making sure you're using a soft toothbrush, right? So you don't have bleeding gums. What's one of the little, do you ever hear of the little red dots that you might see on someone? What are they? Petechiae, exactly, all right? That could be something that you're noticing. That might be a risk for sure. So those are some of the issues. Wow, guys, we're doing pretty good here. Can you believe it's 9 o'clock? Wow. Do you think we've covered quite a lot, right? You want to keep going? Got one more hour.
Yes.
I haven't bored you crazy yet. Not too much anyway. All right. Bear in mind, let's think about some of these. One of them, yeah. Do you know methylphenidate? What is methylphenidate, by the way? It's on your little list of things. Handy little drug. You could probably all do with it right now.
Is it for ADHD?
Yes, it is. That's exactly what it's for. It is indeed. It's a form of Adderall, right? It's a methamphetamine. So let's think about this. What are the side effects of these meds? What would be part of the teaching? First of all,
Take it in the morning.
Beg your pardon?
Take it in the morning.
Yeah, I hope so. Unless you're a night owl, right? Let's think about this. It tends to be given to children, doesn't it, for ADHD? Unless you want your kids bouncing off the walls at 10 o'clock at night, you're probably going to give it in the morning, yeah? What else are you going to check for? Because what's some of the side effects of this med?
Does it increase heart rate?
It absolutely can. Yeah. It's an amphetamine. Well, one of the things that we need to be aware, especially with children, right? We want to monitor their growth, because what do these meds do? The problem is with these types of drugs is that they suppress the appetite. So we do want to be careful that we're making sure that our children are still reaching their growth. That they're eating well, that they're sleeping well. We may have to do medication holidays with these types of meds, for instance. But I'm just actually going to look something up for you, because I want to see if there's anything else, because I'm talking off the top of my head with these, only because I teach it. So I want to make sure that I'm not missing anything with these sort of stimulants, because this is what it is. It's a stimulant for sure. But give me a minute, because I'm concerned. For some reason, it's on your list, and I want to make sure that I'm not missing anything with this particular medication. And again, I don't know. Oh, yeah. Yeah, methylphenidate, Ritalin. It's the first one. So again, I would say that one of the big issues, one of the big side effects is making sure that, especially children, that we're going to suppress the appetite. We don't want to suppress it too much, that's for sure. It can cause palpitations, like you said. It can increase the blood pressure. So those are some of the concerns that we could potentially have with these meds. Let me just see if there's anything else. I think that's, and you know, it's a, you do know it's a Schedule 2, not Schedule 2, I think it's like a Schedule 4 drug, actually, not Schedule 2, but it is a controlled substance, right? So you can only normally get like a 30-day supply. You only get it like each month. So that's one of the issues with it. Let me look through some of these other pieces. Oh yeah, statins. Let's have a quick look at statins. And then I think what we'll do, as I say, I will make sure there's so much more information here that I have for you. Just bullet points of all sorts of different areas that I wanted to sort of, you know, that I want you to have just in case. Scopolamine patches. Scopolamine. So
Reduces secretions.
it does. What is it? What did I say earlier on that what sort of class is it in? Is it a cholinergic? Is it an anticholinergic? It's an anticholinergic. Absolutely. So it is going to, you know, oh, hello. Let me bring it back in. There you go. It is an anticholinergic, absolutely. So it's going to block that cholinergic effect. All right. And let's see, what else is it going to do? It's going to help with nausea. We said that. It's a patch. How long do they wear the patches for?
3 days. It can be rotated.
Yeah, 72 hours for sure. Please make sure you wear your gloves. Some of you may or may not remember my story about my scopolamine patch. Remember, it's an anticholinergic, right? So anticholinergics, they reduce, you know, they're going to dry everything up, secretions, all that sort of stuff. But what is it going to do to the eyes?
It's gonna dilate the eyelids.
Exactly. Going to dilate your eyes. Yeah. So just to help you remember that, I'm not great on a boat, and I put a scopolamine patch on to help me with, you know, nausea on the boat type of thing. And yeah, that was fun because, of course, I didn't have gloves on when I did it. Put my patch on. A little later, I wasn't thinking, rub my eye, and then I couldn't see for the rest of the day. I had one dilated pupil, not the other one, and actually was concerned I had had a stroke, which thankfully I haven't. But so just be aware that it will dilate the pupil, right? For sure. That's what scopolamine, that's what basically these anticholinergics do, which is great if that's what you want it to do, but not for me, for sure. It does cause sedation. It does cause drowsiness. So, of course, what would be a teaching point?
Don't operate. Don't drive.
Yeah, yeah. You know, don't do anything that is going to put you at risk, of course, like operating machinery or driving, things of that nature. You need mental clarity. So that's something to bear in mind. All right, let me Let me look at some of these. Oh yeah. So that's that. Give me a second. I had a lot of stuff in here, by the way, about eye drops, myotics, which are your cholinergics, and then of course your mydriatics, which are your anticholinergics. And I've just put all of that in here. That might be helpful for you. There are some stuff as well about diuretics, bronchodilators, things of that nature. By the way, I think it was you, Andrew, that mentioned about acetylcysteine being the antidote for acetaminophen, correct? Is that right?
Yes, ma'am.
Mm-hmm. Acetylcysteine as well, just FYI, is also known as mucomist, which is a mucolytic. So sometimes they'll use acetylcysteine not necessarily as an antidote, but also they can use it as a mucolytic. So just, you may see that in some way. I'm trying to look for something else. Fosamax. It's on your little list. I'm looking at your list of the pieces that they wanted us to go through. Fosamax. Let me look that one up for you because I want to make sure that I tell you all the right stuff about Fosamax. So give me a second. Pardon?
Is that for the bone?
Yeah, it is. It's for osteoarthritis, but there's a few pieces to it that sometimes come up, and I just want to look and make sure that I'm telling you all the pieces. So just give me a second here, and yeah.